It is my very great pleasure to be here today on behalf of the Lancet and the Lancet Global Health, and to welcome you all to this panel discussion on some of the efforts underway to fight newborn infections. I would like to first acknowledge the individuals who have worked incredibly hard to put the panel together and to arrange the event, to the panelists themselves, who, as you'll hear, bring with them an eclectic and rich set of perspectives, and to the organizations who have made all of this possible: Gates, Johns Hopkins, USAID, and Save the Children. So why we're here and what we'll be discussing today is fundamentally about the ongoing pursuit of improving health outcomes around the world, and specifically leveling the playing field so that all newborns are given the same opportunity to survive and to thrive. And it might be a bit unusual to start a panel discussion with a quote from a saint, but I think that this is especially apropos to invoke the quote from a scribe to Francis of Assisi, which is, "Start by doing what's necessary, then do what's possible, and suddenly you're doing the impossible." And the studies, findings, and implications that will be discussed this morning truly exemplify this notion and pursuit. What's necessary? And the backdrop of these studies is how to move the needle in preventing neonatal deaths from treatable infections. And this is also really a branch point for innovation and design of safe and effective interventions in settings where hospitalization is not possible. So then what is possible? How can the cascade and delivery of care reach babies where resources are limited and barriers to access are manifold? Moreover, how can this be done in a way that reflects, respects, and is in line with the culture and the community? And these studies in many ways represent what was once thought impossible and provide novel and much needed evidence that may help to save more newborn lives. And it's moments like today where evidence can be shared that gives hope and builds momentum to making progress in these very critical issues in global health. So on that note, I'd like to get started. I'd first like to introduce Katie Taylor, who is the Deputy Assistant Administrator and Deputy Child and Maternal Health Coordinator of Ending Preventable Child and Maternal Deaths at USAID.
Thank you. I'm delighted to be here with our colleagues, friends, and partners from Johns Hopkins, Save the Children, the Bill and Melinda Gates Foundation, the College of Medicine, Ibadan, and the Lancet to share this new evidence. It's very exciting. Now, I brought a prop. She's not a prop. She's a newborn. She's neonatally. And part of the reason I brought neonatally was I wanted us to start by picturing the reality of what we're talking about. Imagine, if you will, that neonatally has just been brought home, but she lives by her mother, her father, her very proud new grandmother, but they live in a very poor and remote setting, and suddenly neonataly's not feeling well. And mom and dad and grandma are all worried, oh, she's not eating, or she's breathing poorly, or what is the matter? And as they try to think about what to do and decide what to do, time passes, very precious time for this newborn, delicate, fragile baby. And so they may decide to go to a health hut if there is one nearby. And yet there, perhaps they might be turned away because the condition is too serious and they don't know how to treat it. They may be sent to a hospital. The hospital might be closed, or the newborn ward might be full, and they may be sent to a third hospital. So during this time, her life might be ebbing away, and yet there's so much that we can do. And what we're here to talk about today is studies that give us the evidence to bring the needed care closer to Natalie. Hospital care is wonderful in places that have hospitals. We're lucky in this country and other developed countries. But when you don't, how do we take the necessary care? And how do we know that that care can potentially provide as good results as you would have in a hospital setting? That's why we're here. So we think these deaths can be prevented, and we're trying to support through research and other innovations, all the sorts of things that that can help. I mean, I'm going to put neonatally down for a little bit and get some more props. So they're there, dear. In fact, I'll cover her up. I don't want you to think I'm ignoring her. She's breathing great now. We've been looking through through our 24 priority countries for USAID. And across these, we've seen that in the areas where we work, there are some interventions that we've been very good at bringing up to scale in the areas where we work, such as resuscitation, which is at scale in 20 to 24 countries. And I'm bringing out the penguin sucker, which is one of the types of innovations that we help develop with organizations like PATH and others to help unclog the airways. There are many other things that we do. We also focus on newborn sepsis. So we've been very good at taking things like, and I'm trying to find a tube of chlorhexidine, which I have here. I'll find it later and show it to you, which is an antiseptic for cord care. The key idea being that if we can be successful in the sorts of public-private partnerships like helping babies breathe that we do with many of the partners here, to get resuscitation to be done at scale, which is one of the biggest killers, then why can't we do it for antibiotics to ensure that that quarter of deaths, that 25% of newborn deaths, potentially half in some low-resource settings, gets the care that they deserve. So we're here to promote the evidence. We continue to sustain innovations, and we have to do it through the types of partnerships that this panel represents. So I want to thank you once again for being here. We're really, really delighted and excited about the research results and about the work that implies. Back to you.
Thank you. Next up, we'll be hearing from Dr. Abdullah Baki, who is a professor and director of the International Center for Maternal and Newborn Health at the Bloomberg School of Public Health at Johns Hopkins University.
Good morning. So Katie Taylor made this point. I think that many infants and newborn and young infants who are less than 2 months of age die of infection. I think the estimate for newborn is about 629,000 deaths per year. And also there are additional deaths in the second month of life. And they die simply because they don't have access to the currently recommended therapy, which is hospitalization and treatment with injectable antibiotic for 7 to 10 days. So we're talking about that kind of setting where really currently recommended care, which is hospitalization, is not available or not accessible. And so we are here to tell you that I think we have been able to identify simpler options to treat severe infection in newborns and young infants. So options that can be delivered as outpatient or even in the community. But we have to keep in mind that I think this is for settings where hospitalization is not possible. So what we have done is really to develop, identify treatment options that can be delivered as outpatient or in the community. We conducted 3 coordinated studies in South Asia and Sub-Saharan Africa in 5 countries in Bangladesh, Pakistan, and 3 countries of Africa, DRC, Kenya, and Nigeria. So I am going to talk about the Bangladesh study. Mostly my colleague Ayede will talk about the Africa's trial. The Bangladesh study was conducted by our group known as the Adejumoke Research Group. That's in Bangladesh. That's the group in Bangladesh. So I work for Johns Hopkins University Center for Maternal and Newborn Health, and we have worked with the Bangladesh Ministry of Health and Bangladesh institutions to develop this research partnership that is known as Adejumoke in Bangladesh. We have conducted a series of studies over the last 14 years, beginning in 2001, and provided evidence for a number of simple cost-effective interventions. We also supported policy formulation and program development. I'll just give you one example. Between 2001 and 2006, we developed a simple community-based package of care to reduce neonatal mortality. And so the intervention involved promotion of care during pregnancy, delivery, and postpartum period, and also essential newborn care. And so these interventions are provided by locally recruited women trained as community health workers. And they made home visits during pregnancy to teach mothers what care they should seek, what are the danger signs during pregnancy or in a newborn, and where to seek care. But also these health workers are trained to assess newborn and identify severe infection in newborns and manage those cases. And what was the management? Management was to identify severe infection in newborns and refer them to hospitals. But if referral was not possible, treat them with injectable antibiotics. There's 2 injections, gentamicin and procaine-penicillin, daily for 7 days. That's 14 injections. So I think what we have learned, I think we have shown that the package we evaluated reduced the mortality by 34%. That was the overall reduction. But also it showed that I think this was a effectiveness kind of trials. Everybody did not get the recommended visits during the postpartum period, early postpartum period. But those who did, they had a 2/3 lower mortality compared to those who did not receive. So these lessons really contributed to the design of national neonatal health strategy in Bangladesh, but also the WHO UNICEF recommendation for early postnatal home visit as a strategy for newborn survival. Regarding the newborn case management by trained community health workers, what we learned is these health workers can use simple clinical tools to identify sick babies or babies with severe infection. They referred all of these babies with severe infection, but only 1/3 complied with the referral. So 1/3 of the families are able to go to the hospital. So if the family was not able to go to the hospital, the health worker offered treatment at home using injectable antibiotics. About 40% consented to treatment, and about 25% refused both types of care. So we have seen that the treatment, 7-day injectable therapy treatment by community health workers at home is safe and effective. So we published that data. That's out there. I think what was troubling, though, that this 25% of the families refused both hospital care and the home care. I think their concern was the health worker giving 14 injections to a small baby, and they didn't like it. So, and what happened? 1/3 of those babies died, those who refused both types of care. So that indicated that there's a need for simplification of the current treatment regimen. And in 2007, when we really came up with this result, I think there are other studies around, so we are not the only one working on it. So USAID, WHO, Saving Newborn Lives, convened an expert consultation to look at what we learned about community case management or management of severe infection in newborns. And so the expert consult group also concluded that there's a need to simplify treatment, come up with a simpler antibiotic treatment. That will be the crucial next step. So we took that lead, developed the Bangladesh study, and started a study in 2009, and took some time. I think so. The study was conducted in 4 hospitals of Bangladesh and a rural field site. We screened about 75,000 young infants. 3,100 had signs of what we call severe infection. All of them were offered hospitalization, but only 20% accepted hospitalization, 80% refused hospitalization. So this study was done among those who refused hospitalization, 80% of them refused. And if the family consented, they were allocated to what we say, 2 simpler regimen and the standard regimen. So the standard treatment regimen was, again, procaine, penicillin, gentamicin for 7 days. So that's 14 injections. The simpler regimen had gentamicin for 7 days along with oral amoxicillin, that's 7 injections. And then the second alternative was penicillin, procaine, penicillin, and gentamicin for 2 days, switching to oral amoxicillin. So that was 4 injections. The main outcome was treatment failure, meaning that I think the babies were not responding to the therapy. And so we followed them at home and found out that the treatment failure rates are same. So it's really 10% in the standard, 8% in each of the alternative therapies. We also looked at mortality, of course, and which was low, 2% in all groups. So really, I think that's a good news. I think so now we have simpler option, but again, for setting where hospital care is not available, and I think these options should be more feasible to deliver, should be more acceptable to families, and if we can implement it at a scale, and it has the potential to reduce many newborn and young infant deaths. So what we need now is to develop context-specific strategies, because every setting is different. The health system is, Ethiopia is different from Bangladesh, and Tanzania is different from India. So I think so you have to work to develop strategies for each setting and see how can we implement these simplest interventions with high coverage and quality. And that will require quite a bit input in terms of training health workers, strengthening the primary healthcare system. So that is our next job. Thank you.
I'd like to next introduce Dr. Ayede Adejumoke, who is senior lecturer and researcher at Department of Pediatrics, College of Medicine in the University of Ibadan, and a consultant pediatrician at the University College of Hospital at Ibadan, also in Nigeria.
Thank you. Good morning, everybody. I'm going to talk briefly about the African study called AFRINEST. The full meaning of AFRINEST is African Neonatal Sepsis Trial. This was actually a multi-center clinical trial that was funded by Bill and Melinda Gates Foundation through a grant given to WHO. World Health Organization was actually the supervising organization providing the technical experts for this study. They also provided the supervision and monitoring functions also for the study. The sites involved in this study were actually 3 countries, namely Democratic Republic of Congo, Kenya, and Nigeria. Each country, Kenya and the Democratic Republic of Congo, had 1 site each, while Nigeria had 3 sites, 1 site in the northern part, that's Zaria, and 2 sites in the southern part of Nigeria, in University of Ife, Ile-Ife, and then also Ibadan, coordinated by University of Ibadan. I'm actually representing the 5 principal investigators. My site is Ibadan. What was done in this study and how was it done? The aim of the study was actually to evaluate simpler antibiotics that can be given to newborns when they do not have access to hospitalization. So the study was actually an individually randomized one, open-labeled, multi-center and equivalence trial. What we did was to identify pregnancies as early as possible and to have 2 home visits in pregnancy so that births could be identified early. And also there was active surveillance for illnesses in those newborns as they were followed up 3 times in the first week of life, thereafter weekly till age 59 days. This was actually done in all the centers by community health extension workers who were trained on the UNICEF WHO home-based care package. Screening and treatment, as well as allotment to treatment regimen, were actually done by trained health workers. In Nigeria, this was done by nurses. Also in Democratic Republic of Congo and Kenya, the same set of trained health workers were used. There were 3 different regimens as intervention and 1 as control. The control treatment was actually the standard treatment, which is currently recommended, and that is procaine, penicillin, and gentamicin for 7 days. The intervention regimen had series of injections with decreasing in number. We had the first intervention group that had 7 days of gentamicin, and also oral amoxicillin that consists of 7 injections, and another group that had 4 injections, namely gentamicin for 2 days, daily for 2 days, and also procaine penicillin daily for 2 days. The 3rd intervention group had only 2 injections, that is IM intramuscular gentamicin for 2 days daily, and also oral amoxicillin for 7 days. What did we find in this study? We actually had over 95,000 pregnant mothers that were followed up, and we also identified over 85,000 babies. So we agree with me that this was actually a very large sample size clinical trial relative to what has been done previously in Africa. Then the numbers that were enrolled in the study was over 3,000. Only 200 failed the per protocol analysis. So we actually evaluated some parameters in those babies. We had treatment failure evaluation. We also had relapse evaluation, clinical deterioration, death within 2 weeks, and also the secondary analysis. In all the groups, both the control group as well as intervention groups, these things that were evaluated were actually similar in both groups. The compliance was also noticed to reduce as the number of injections were actually increasing. So the maximum, the best compliance was actually obtained with the last two regimens, with the simplest regimen, with the smallest number of injections. Then also, there were some things that were actually innovations in this study. First of all is the first multi-center clinical trial that will look into newborns and young infants in Africa. Then also is the first one to look into specific situations in which hospitalization is not possible. Then secondly, this particular trial was actually conducted in a programmatic setting. In all the countries, what was done was that we used the health structures on ground, and this is actually very, very peculiar in the sense of thinking about scale-up of the program and, of course, overall acceptability for all stakeholders. Then also in this particular study, several regimens were used, comparing to control. So we had three regimens. Then fourthly, we also considered first-level health facility treatment. This is the first time this will also be considered. And then overall, this study has actually filled the gap of what can be done in cases in which hospitalization is not possible for newborn with severe infections on outpatient basis. We also realized that this study was conducted in different geographical situations, different cultural environment, different administrative environment, and then also giving us similar findings. And this will actually aid generalizability of the results. Are there policy implications for this study in Africa? The answer is yes. Number one, we need to choose and recommend which best antibiotics to be used in newborns where hospitalization is not possible. If that will be done, there is also the need to strengthen the health facilities and provide commodities, particularly the gentamicin that is currently at a relatively high dose, 40 milligram per ml. One would think about getting smaller doses in form of 20 milligram per ml for easy administration. Then also, in this study, a lot of training was actually done for all the various levels. So training will also be included. Then for such babies, there will also be need for home visit after treatment for them to be properly followed up. Are there strengths of this study? Other strengths that one we want to mention. Number one, the large sample size is a good one, so it can be used for Africa. Then also there is community-based multi-center study. This is the first time it will be done. It's also a prospective study, and that is a good one. Then in the study, we also had a relatively high rate of follow-up, and that makes the results very tangible. Then also, we also documented good adherence in the study. The adherence rate was very, very high. Then also at the completion of the randomization, all the baseline characteristics were similar in all the groups. That shows that the randomization was properly done. And all these are strengths also for the study, for policy implications. So thank you for listening.
Thanks very much. The next speaker that we have is Dr. Mariam Clayson, who is the Director of Maternal and Newborn Child Health at the Bill and Melinda Gates Foundation.
Thank you, Rebecca. Colleagues and distinguished panelists, I hope it's obvious to all of us here that we are here today talking about a game changer in global health. This is a very important moment for all of us who are concerned about newborns, their mothers. And what I would like to spend a few minutes is really talking about the global implications of these findings that we've heard about, and also bring it back to neonatally and her mother. Because I think it's very important to underscore what, as Katie did, what this really means. What does it mean for a mother in rural Kenya who's just discovered that her child has fever, who maybe live in quite a distance from the nearest health professional doctor? And many of you know that used to be a death sentence for a newborn with sepsis without access to a hospital or a physician. And I think it's important to contrast that with the big numbers that you're all familiar with. We could talk big numbers here. We could talk about the 44% of the under 5 deaths that are caused by newborns dying from things that we can all prevent, dying from the fact that they aren't breastfed, aren't having access to simplified antibiotics, aren't put at the breast, skin-to-skin contact. Despite all of these available interventions, still 44% of all under 5 are newborn who die from preventable causes. We could also talk about other big numbers, the 600,000 newborns who die because of sepsis. But instead of the big numbers, let's focus on that, again, on that mother in rural Kenya. A child is feverish, what does she do? Now, as you have heard, we have this game changer. If there is a skilled health worker in her community who both can identify fever, identify a problem, and is enabled and empowered to deal with it, to provide the antibiotics that are needed according to these new simplified treatments, then we can prevent that death. It's huge. It's huge for global health and for newborn care. In the past, and in the current still for many, the barriers are just too hard to overcome for a mother in a rural community with a child with fever, and a newborn with fever in particular. The barriers, the distance we've heard about, the long treatment, the 40 antibiotics by a physician in a hospital, is just not a feasible option for most mothers in rural communities. So here we have the change that we're talking about. No baby should die from serious infection. No family, mother or father, has to actually accept this fate today. Last year, we had the Every Newborn Action Plan that sort of catapulted newborn onto the stage of the global agenda. Countries are busy trying to translate this Every Newborn Action Plan now into practice for newborn. Nigeria, India, Ethiopia, several countries have launched an Every Newborn Action Plan to try to deliver on these commitments. So here is an opportunity that we haven't had before for newborn. The time now, as we all feel, is to accelerate progress on maternal and newborn health. We know that the health of that mother and the newborn is really closely linked. When a woman is empowered and have access to family planning information and services so that she can time and space her pregnancy, she's more likely to survive, and her newborn is more likely to survive and develop into a healthy newborn. A healthy newborn is more likely to thrive and develop into that young adult and then into that woman and mother. So these are all really tightly linked together in a virtuous cycle, which really points at the significance of trying to prioritize the well-being of newborns in the continuum of care. 2015 is a critical year. We must continue to make sure that we keep women, children, and newborn at the center of the global agenda, in the center of the Sustainable Development Agenda. Simplifying antibiotic regimen that we talked about today brings life-saving interventions closer to the newborn in need. It gives us that boost that we need. It gives us confidence in what we're talking about, confidence that we can deliver on our commitments and reach out with life-saving interventions to those most in need. Thank you.
Thank you. Our last speaker today is Joy Riggs-Perla, who is the Senior Director of the Saving Newborn Lives program at Save the Children.
Well, good morning, everybody. It's always a very tough job to be last on a group of distinguished panelists like this, but I think what I might do is just sort of reinforce some of the points that have already come out. Mariam said that this was a game changer. It's really a landmark study, and I think it's very exciting, and it's hard to underemphasize that. As a result of the publication that you're hearing about today, there's going to be a lot of interest at the country level in trying to push these services down to the lowest level health facility so as many children as possible can be reached. One of the key challenges, though, that health program managers at the country level are going to face is how to get the same results that the study achieved under normal program circumstances. I think we have to remember that the conditions in this research trial were highly monitored, very intensively followed up, and so they aren't truly representative of what you'd find in normal program settings. And I think that Katie made the point most nicely with her neonatally, but I'd just like to underscore the fact that there are certain conditions that have to be in place for this intervention to be effective. To begin with, babies need to be brought for treatment. I mean, the parents need to recognize there's a problem and they have to seek care. Secondly, the care has to be initiated early enough so that severe infections can be treated quickly. Otherwise, there isn't much point. When the mother arrives at the center, at the health center, there has to be a health worker present to actually initiate treatment, and there have to be drugs available and on hand. And finally, follow-up, as you've heard, is extremely important. So you've heard about the treatment failures, and those need to be investigated so that we don't let any of the babies die who have initiated treatment. So these conditions that several of our speakers have mentioned that I've underlined here mean an investment in health systems. Now, no one wants to talk about health systems, but it's extremely important to focus on improving not just newborn services, but services for mothers and newborns, improving the quality of that first-line health facility so that when women go there, they're getting the treatment that's appropriate. The other point, I think, just to add to that, we have to remember that the drugs we're talking about today are decades old. These are not new or costly drugs. They should be readily available. So that, in a sense, makes our job a bit easier. The second point here is that going forward, in order to achieve the kind of results that we've seen from these research trials, we really have to take an ongoing learning approach. We really have to learn by doing and then share that knowledge widely so that other countries with areas with low resource settings can learn from what's been done as we go along. And that should include learning about prevention as well as treatment. It isn't just treating children, it's also learning how to prevent the infections from beginning to take hold to begin with. So the expansion itself has to be done carefully. There needs to be implementation research associated with expansion, and all of these things are elements of the program that international donors and partners can assist with. And then finally, I think I have to say something about what a marvelous multi-partner effort this was. I think partners very early on recognized the fact that the power of the outcomes of this study, the results would be much more convincing if it were coordinated, if similar methodologies were used, and the studies were comparable across sites. So while I wasn't around, I really congratulate all of you who recognized that and made sure that that happened. And finally, let me make a quick pitch. I think that the AFRINEST and SATT trials are going to be very much the subject of the upcoming Maternal and Newborn Conference that's being planned for October in Mexico City. I hope all of you have started to hear about it. And we certainly hope to have panel discussions and a lot more exploration of what this means for countries, because hopefully by that time we'll have WHO guidelines as well, so it should be a very rich discussion. If you want to know more about the conference, there are flyers in the back of the room, and also there are extra copies of every newborn action plan that Mariam referred to if you would like a hard copy back there as well. Thank you very much.
Thank you. We now have time for questions, but before we begin that, I'd like to just remind you to wait until you receive the microphone as we're recording this. And if you could state your name and affiliation before you have a question. We can start up here. We have one question up here. Perhaps we can go here, and then over here, this gentleman right here.
Thanks. David Oop from Save the Children. I guess what I would be interested in is whether or not it's felt, first of all, really appreciate the sharing of this very important research. As several people have said, this has important global implications. I guess my question is, do we feel collectively that we have now the body of evidence that's sufficient to be able to inform a more formal change, if you will, in guidance and guidelines related to the treatment of sepsis in the newborn? And if so, what actions are expected to be taken over what kind of a timeline?
Abdullah, do you want to
Yeah,
take that?
okay. That's a very good question. I think you know that the global policy is set by WHO. So as soon as the studies are completed about a year ago, WHO convened a meeting, and all the results are presented. WHO, in fact, went ahead and established an evidence review team to look at the results. And I was in one meeting, and I know that my colleagues Neil Brandis, Steve Wall, they're in a second meeting. And we think that the process is underway, and there will be a formal policy change by WHO soon.
This gentleman right here in the second row.
Good morning. My name is Oscar Cordon from Chemonics International. I think the question is for Abdullah and Ayede. I'm curious about any report from the field in terms of the use of injectables for the community health workers, difficulties, challenges, obstacles, administering the drugs? Logistically speaking, or technically speaking, or clinically speaking?
Sure. So I think these trials are somewhat different. Maybe I'll start and Ayede can follow. So in Bangladesh trial actually used physician for this particular trial and wanted to safeguard the safety of the newborns, young infants. But I mentioned about earlier studies where I used community health workers to treat again newborn infection when the families are not able to go to a hospital. And so we treated in that study about 500 sick newborns with 2 injections for 7 days. And there was really no side effect. I think what can happen, I think the gentamicin and procaine penicillin, these are really drugs we always use. I think there are side effects with all drugs, but we didn't see, I think there could be local infection, we didn't see that. But also you have to keep in mind that these are very well-trained health workers. So I'll emphasize the need for training the health workers well, monitoring, and also following up those kids. You know?
I believe this woman right here was next.
Miriam has a
Oh, I'm sorry.
One more point from AFRINEST. The main challenge we got was the ensuring the appropriate doses. Since we had 40 milligrams per ml of gentamicin, we emphasized this challenge, and this was incorporated into the training of the community health extension workers and the nurses. Because in Nigeria, we have a unique system in that the community health extension workers have formal training. They are the least trained health workers in Nigeria. So this was actually considered.
Mariam?
I think your question around injectables is really very relevant. And of course, here we are shifting from the current protocol, which is 14 injections to the newborn. So all of us have worked under those circumstances with those protocols of 14 injections. That's really been tough, I think, both for frontline workers as well as for families to accept that their newborn would be subjected to this. So of course, with this new regimen, we are actually addressing to some extent that problem, moving it down to 7 and 2. So that's very important. I think regarding the question of the body of evidence, as my colleague said, there was a very important meeting organized by WHO in the fall, examining these evidence very carefully. So we expect their guidelines to come very soon. Some countries who scrutinize evidence very carefully, as all represented here, have already shifted policy, both Ethiopia and India, towards the seven injectables. So there is already momentum. Because we acknowledge the issues that was raised by my colleague from SNL and SAVE, all intervention, this is an intervention. This is not about, this is about changing practices. So clearly we are working also with the research sites that you heard from, to see how one can use these sites to now provide technical advice for rolling out simplified antibiotics in the countries engaged in this trial. So we think it's so important to very rapidly move from a very solid evidence base that we have to actually bringing this to scale. So that's really the next step.
I believe this woman had a question next. Oh, sorry. Okay, then we'll make sure it gets over here and back.
Hi, Claudia Morrissey Conlon with USAID, Saving Mothers Giving Life. I want to thank the panel. This is an exciting time for newborns, and this is an integral part of pushing that envelope that will really, I think, herald success in the future. I have a question for the PIs. I know WHO obviously will make policy, and that process is underway. But you talk particularly with the AFRINEST that the the arms, it was an equivalency trial, and that the outcomes were the same for all three of those arms, with the last two arms achieving greater compliance. My question to you is, it sounds like we're moving forward with recommendations around 7 injections. Could you give us your ideas about if the equivalency is the same, why we're not looking at those other 2 arms? Thank you.
So maybe I can start. That's a very good point, and there's some differences between the studies. I think the Bangladesh trial looked at 2 alternatives. The AFRINEST looked at 3, and we, of course, shared results of both Bangladesh trial and the Africa trials in Bangladesh first, because we conducted the study in Bangladesh. And so we shared twice. We have been working with policy, Ministry of Health very closely. And while I think, as Mariam said, I think there's a WHO policy, I think we're expecting, but countries are not waiting. I think so she gave example of 2, and Bangladesh also adopted, and what is good is Bangladesh adopted the simplest regimen, which is 2 doses of gentamicin and 7 of amoxicillin, which was not really tried in Bangladesh, but I think the Ministry of Health looked at all the evidence and then decided to adopt that as a national policy. And also there's some implementation efforts started in selected districts.
Okay, the figures concerning the results, like I presented earlier, what we did was to look at treatment failure, and in the last 2 regimen, treatment failure had the least. The range was 5.4 to 8.1. The least figures were for the last 2. Also, relapse had a range of 0.3 to 1. The least were also in the last 2 groups. Then clinical deterioration range was 1 to 2%. Then the death within 2 weeks was also 1 to 2%. And this was actually similar in all the 3 regimens.
Okay, we have a question right here.
I'm Indira Narayanan, an independent consultant. I'd like to congratulate all the speakers and the whole team for this wonderful set of studies, which I think is so useful. My question is related to, you have said that you've dealt with severe sepsis. Maybe we need to look into whether treatment at facility level, especially the higher level facilities, also need to be reviewed, because we do tend to use antibiotics for a much longer period. But I think in addition, we also need one more element, and I don't know whether the group is planning to do this. In severe sepsis, even though clinically we may not actually have features of meningitis, they have shown actually there are cellular infiltrations which are suggestive of involvement. So do you think at least your survivors need to be followed up to see not just, I mean, we are happy with the survival, but we also need to ensure the quality of survival, because the newborn's brain is a developing process. You're also dealing with preterm babies which have even more immature brains.
Abdullah, do you want to start
So
with?
I think both very good points. I think quality of care is a huge issue in the facilities, particularly in the peripheral facilities, is a huge issue. You know that throughout Asia, Africa. So we looked at very closely in Tanzania, and really, yes, quality of care needs to look into, no question about it. But in this study, we didn't look at that. I think this study was I think, conducted in young infants whose families could not or didn't accept hospitalization. But I agree with you that that's another issue we need to look at closely. And so the other point I want to follow up, I think, I agree. I think this is, I think, I've been working on this newborn area for 15 years, and not just these babies. I think we are really saving many newborns through simpler community-based approaches. And I think we can talk about that separately. I think I have some concern that are they surviving with some residual disability? I think that's a concern. I think I agree that there's a need to follow up not just a newborn who had an infection, but also preterm babies, birth asphyxiated babies. There's a need for it, and we can talk about that more.
I think there was another question over here. Here, I guess we've got the microphone there. We'll start there and there. Oh, you've got it. Okay, great. Go ahead. Yes.
Good morning. Dr. Al Bartlett, retired. I want to thank the panel for this and bringing this long quest to an almost conclusion. The publication is very exciting. Thank you for being with us today. And thanks also to the Lancet for your continuing commitment to maternal, newborn, and child health in this context of the MDGs and beyond. It's been there for a long time. Thank you. I want to make a point that this is an exciting finding that brings up an old problem, because the intervention is not the antibiotic. The intervention is community assessment and treatment with antibiotic of sick babies. And that goes back to the problems we had with oral treatment of with antibiotics for children with pneumonia in Nepal, where the original finding was treat with oral antibiotics. The real finding was community health workers identifying and treating sick children with antibiotics. So the question to the panel is, how do we finally use this finding to get those countries that do not have a strong commitment to community health care delivery as part of their health system? Only a few countries really do. Nepal, Ethiopia, a few others. Choose in Nigeria, variable, maybe, but very variable. So how do we really get the commitment and the resources we need to operationalize that commitment to this effective delivery approach, which has been shown for intervention after intervention to make a difference in survival and health of women and children?
That's a great question. Do you want to start with this, or Mariam?
I can kick off, and then
Yeah,
I think all of us have comments.
We all
that,
have opinions.
You know, that, honestly, that's why this is so exciting, that this intervention, as you say, it's not a drug. It's an intervention, comes at this point in time when there is such strong commitment from all governments to the Every Newborn Action Plan. The World Health Assembly last year, countries stood up and made that commitment, and at the country level, that's now being launched and rolled out. So here suddenly we have both the context that we need, the political commitment. Hopefully we also get increasingly the voice of communities saying this is not acceptable to us. So we are hoping that there will be a social movement around this. The interventions are there, the movement is there, and I'm sure my colleague from Nigeria can talk about more of the movement around this, that this is not acceptable. And we hope that is what's going to drive coverage of key interventions at the community level, and to look at this, which I think many do, as the continuum, the family, the community, and the facility. It's not an either or, it's really about the continuum of families, communities, and facilities.
Yeah, concerning Nigeria, the stage is actually set. In 2014, November, we had the first neonatal conference ever in the country, and there were many stakeholders: the Pediatric Association of Nigeria, the Neonatal Society of Nigeria, the international agencies, the Federal Ministry of Health, national, primary health care development agencies. There were many of them that were involved for promoting activities meant for newborn survival in Nigeria. Then secondly, these research findings has actually been presented in Nigeria twice. The first one was in September 2013, after the completion of the AFRINEST study across the 3 countries in Africa. The second one was first week in March this year, after pulling the results from SATT and AFRINEST. And this was actually also well attended to, with the directors and the ministers, the commissioners also being involved in this particular rollout program. So I think already we have a setup that will encourage the roll-up of this program. It's been accepted even from community level to national level.
So your question, I think this is a very important question. I think, can health workers or frontline workers identify sick or severe infection in neonates, young infant, is a very important question. And so we looked at that. We looked at that in earlier studies, and we compared health workers' assessment with physicians' assessment, and we showed that the health workers can identify sick infants requiring hospital care or antibiotic therapy with a very high sensitivity specificity. Those are published. So, but the point is really, those are again studies, in a study setting, and your concern still is very valid. I think when you scale up, can we ensure that the health workers will not be treating missing cases or treating too many cases? Both those are a very, very valid concern we have to pay attention to. And that's why I think, as earlier I mentioned, that there's still a huge need to really strengthen the healthcare system. I think in terms of training, of course, of the health workers, supervision, support, those will be needed.
So I interpreted the question a little bit differently, which is what I heard you say is we have decades of experience and examples of how engaging communities in the assessment of conditions and preventing and treating those works, and how do we scale up and replicate that? And I think we're actually in the process of doing that. I suspect all of us on this panel and possibly many in this room are engaged with that. At USAID, an organization you know intimately, our flagship program on maternal child survival has a very strong component of community health. As do many other of our mechanisms. But we don't only want to do this with our resources, it's also with our voice. And so how do we, I think what you're posing is the question of replicability in a systematic way to ensure that countries nationally can see this as an integral part of building sustainable, strong health systems, particularly at the primary care level, but also as in that continuum of care. So we are working on that every day, and I think it's a great point.
And Joy. Oh, please.
Obviously, you've touched a nerve here, Al. We all want to speak to this. But I think it occurs to me that part of the answer to getting attention at the policy level to investments in community health is really to talk constantly not just about the supply part of it, but also the demand part of it. Because if you don't have households and mothers and others at the community level doing what they're supposed to be doing to make sure that the sick infant connects with the health system, no amount of strengthening of the health system is going to amount to a hill of beans. So if we talk constantly, if we make the investments in looking at health-seeking behavior, what drives it, what the community wants, I think it naturally leads policymakers to think, well, you know, maybe we need to pay attention to that. So one of the things that we're doing in the Saving Newborn Lives program is to invest much more in care-seeking behavior studies and directing people's attention to that part of the equation.
Thank you. I think there's a question in the back.
Hi, Bina Valsenkar from Save the Children. The SATT and AFRINEST trial results are impressive, and I think the general pediatrics community, neonatology communities, professional communities across the world will also find them impressive, but we'll probably feel uneasy with the idea of treating newborn sepsis with simplified regimens on an outpatient basis. So in addition to the evidence itself, what kinds of things can we say to reassure these communities about the simplified regimens and the trial results?
Mariam looks ready
You know,
to go here.
it's very funny because this moment to me reminds me of when oral rehydration salts were launched. And Lancet, thank you, at that time said oral rehydration solution, ORS, is the scientific breakthrough of this decade, they said. And it took very long time for pediatric communities to both recognize the fact that frontline health workers could do an equally good job with this if all these conditions we're talking about is in place, and it took time. And here I think we have one of the scientific implementation, scientific breakthroughs of this decade, that you can actually treat newborns with a severe illness with a simplified regimen that could be in the hand of well-equipped, trained, and motivated health workers. I see a parallel there, and yes, I think it's going to take time, it's going to be debated, and that's why this study is so important. It's so important that we sit here talking about this intervention on a very solid evidence base. Several studies in Africa, several in Asia. There's one still coming in Pakistan. So I think that is what gives us confidence, and what we, of course, hope as activists and evidence-driven advocates is that we shorten the time between research findings and convincing evidence to scale up. We find it often these time lags really unacceptable, frankly. So how can we work together to create the conditions so that we can scale up and reach out with known intervention at much shorter time lag? So that this, as you say, it should be debated, the evidence should be examined, but let's make sure as we do that, that we move fast to create the conditions. It's unacceptable that 600,000 newborns are dying from things that they do not die from here. So how can we all work together to respond to your very important question?
Thank you. There's a question over here.
Eric Sario with Maternal and Child Survival Programs, a community health team. So thanks for the panel, fantastic breakthrough, and it's nice to see so much research going in the same direction. But there's a couple of points that have been raised by different panelists, you know, and right now even talking about how do we scale up and contextualization, and we're going to need implementation research. So if you think about health systems and health systems managers in the countries where we want to work and we're working, the issues is not to add interventions or even add simplified interventions, which is all the better. The issues are multiplicative. Once you add more interventions, the management issues are multiplicative. There's really much more to manage than 1 + 1. And so do you think, that's a biased question, I'll grant it, but do you think we're going to see the same kind of commitment to research now that we have this groundbreaking controlled efficacy demonstration on large scale? Are we going to see as much commitment to do implementation research and systems, you know, systems influenced research to look at quality, to look at integration and what happens when you integrate this life-saving intervention with CCM, with other interventions, and the displacement and intended effects, the quality, the institutionalization and adaptability over time? We know these issues, as all these trials, the decision is based on distance and accessibility to services. And that distance and accessibility evolves in our countries. There's, you know, the health services are reaching further out, so we want to build systems in communities. I'm all for community-based service delivery, but they also have to adapt because the environment is changing. How are we going to study this, and are we going to be able to have the resources to do that?
I was going to say Miriam or Joy.
Well, I think you have good points, and I think that there may be some reluctance on the part of governments that are cash-strapped to make investments in implementation research because it sounds like more research. And in our program, we call it program-based evidence to avoid the word research because it needs to be done, and someone needs to invest in it. But I think here's where partners can play an important role. Development partners can step in and help do some of that work and accelerate the process of sharing that information through good knowledge management. As Mariam was saying, we can't afford to do this as we did with ORT 20 years ago. We don't have that time luxury. We've got to be faster on our toes. And so I do think that that's an important role that partners can play.
And as one partner, I think we in the Bill and Melinda Gates Foundation really feel that it's an important time to shift our research focus to answer the how questions. We have enough of the what's answered, what to do, but now we really need to invest heavily in how do we scale up. I think the challenges that you brought up can be solved through task shifting. It's not that you add more burden on the frontline workers or the community health workers, but that you really think about them focusing on the most high-yielding, most important interventions and do the task shifting. And Ethiopia is a good example there. They used to expect from frontline workers that they delivered babies. Now they are shifting to focus on this, which frontline community health workers can do well while referring the mother to deliver in the facility. So there are ways looking at the maternal child health together where I think one can do very smart task shifting to ensure that the health workers can really deliver.
And I simply want to echo what Mariam said. We truly believe in doing more on figuring out how we can implement more effectively.
Question up here.
Goldie Mazia from the Maternal Child Survival Project and PATH. I want to go a little bit on Bina's side as the community of pediatricians, but also as an implementer, to ask a question to the investigators specifically on the task shifting, relating to the task shifting. There were probably, I'm assuming, there were probably various grades of illness in these babies that you treated, and probably some percentage of those babies were too sick to take this treatment because they needed supportive treatment. Can you tell us a little bit about how you trained the community health workers or the physicians of the peripheral level, or what was the approach with these babies that really needed probably IV fluids and other? That's probably something that's going to concern the community. Thank you.
Ayede, do you want to start, and then Abdullah?
I can start, sure. Okay, thank you. For the community health extension workers, we had the young IMCI module training. We also had the home-based care training for them. This was also done for the nurses. The other thing that we did for the nurses was the protocol, the specific treatment guidelines, and the standard operating procedures for each stage of the implementation research. But basically, what we did for the critical illness was those babies that had convulsions, loss of consciousness, not feeding at all, cyanosis, bulging fontanelle, or surgical conditions requiring hospitalization, severe dehydration. Those babies were all excluded in this study. They were not treated at all. So during the training, we had a clinical component to the training. Like in the centers in Nigeria, these cases, because they are not very common, the workers were actually taken to tertiary centers for them to see cyanosis clinically, bulging anterior fontanelle, a convulsing newborn, and the training took us several weeks. Then we also had standardization procedures using pediatricians as gold standard, and we had specific margins for errors, and then we identified the best health workers, because when we were doing the training, we had double the size required. So we actually picked the best out of these workers to do the work for us. So we ensured quality. Then we also had a series of retraining. Retraining was actually done within a period of 3 to 6 months. Initially, it was every 3 months. As time went on, when staff were already acclimatized, we increased the duration to 6 months. So these were all put in place.
And Abdullah, did you have anything?
Yeah. I think what Ayede said is right. I think so. These workers are trained to classify young infants into 3 groups. First, I think some of them had no signs, but those who had some signs of infection, they are categorized into 3 groups. So fast breathing only, that's what she said, and then the infants with critical signs, convulsion, unconscious, they are excluded. And fast breathing alone also was not part of this study. There was a different study in fast breathers only. We didn't talk about it, and they are treated with amoxicillin, oral amoxicillin only, and compared with the standard. But this is the middle group, I think, and many of those young infants have these signs: fever, hypothermia, or low temperature, feeding problem, lethargy, and so basically this is the middle group, and of course chest indrawing. So those 5 signs, and so I treated. And about the training, these workers, of course, are trained, but there's a standardization in a hospital, training and standardization to make sure that they are really identifying the signs. But also there's ongoing quality assurance during the study. So all of those are important to keep in mind when we scale up, so that we train the workers well, we do the standardization, we have some kind of monitoring that they are really identifying sick babies and not really picking up too many babies or missing sick babies. So yes, those will be important.
There's one back here. Is this on? Yeah. Hi. Lily Kak from USAID. I want to congratulate the panelists for a fantastic presentation this morning. And it's taken us 5 years of patient waiting to hear the results today. So I'm really very excited about it. And it all started as a partnership between so many organizations. And I think if we continue in this partnership approach, we will be able to roll it out around the world as rapidly as we can. So, I just want to assure you that this partnership will have our full support. I'm very, very excited about this. So I just wanted to say a couple of things. The model for this approach is really this intervention is meant for families who refuse to take their babies to the facilities. And that's extremely important because we know that that's a huge, care seeking is a huge barrier. But it also means that there are many families that are going to the facilities and are not getting good care. So really, I think we should not turn our backs on, now that we have this new approach, which we know has very strong evidence, we must support that, we must strengthen that to bring this intervention closer to the newborn. But we should, and in doing so, we should not turn our backs on the families who do take their babies to health facilities. We know that infection management in facilities is extremely weak. Systems are really very weak. Supplies aren't available. Providers are not trained. We have this huge IMCI program that is supposed to provide this kind of treatment to babies, and yet they're not being treated. We know this for a fact. So what I would like to make a plea for is that we should have a balanced approach of expanding access to quality care, sepsis management through this community-based approach, and also at the same time continue to strive for good quality care in the health facilities. So my question here is that if we know that the simplified antibiotic regimen is as effective as the standard antibiotic regimen, then in the facilities, shouldn't we also be changing the policy and simplifying it in the facility so more babies can actually get to the facility and we can address that barrier as well? Is there any discussion at WHO about that?
Okay. I think the last point, I think, Lily, we had to exclude babies who accepted hospitalization for ethical reason. We had to offer hospitalization to all babies with severe infection. And in Bangladesh, 20% of the families accepted hospitalization. We had to do that for ethical reason. I think, unfortunately, science, maybe we make progress incrementally. So we couldn't do that. We couldn't offer study participation to all young infants with serious infection. We had to first offer them hospitalization. And that ethical committees required that, IRBs required that as well. So really the study was conducted in infants, young infants whose family refused hospitalization or could not accept hospitalization. And so we cannot say anything about the hospital, but really, can hospital antibiotic regimen be changed? I think that's another question. I think we cannot say anything about that. Yes, I think from the data we cannot say anything. Right. I think your comment about these studies, you may know, that started separately. The Bangladesh study started initially with the, largely with the USAID funding, and then we also had co-funding from SNL. The Pakistan study was supported by SNL and using Gates funding, and then the Africa study started again with the Bill and Melinda Gates Foundation funding to WHO. So, and they started separately, and then I think I really would like to thank the donors. They had the vision to bring the investigators together, which at some point I didn't like because you started the studies. But I think it was a great thing to do. That really, I think that although these 3 studies started separately, I think there was a huge effort, and it also took a lot of flexibility on the part of the donors, and of course for us as well, and to come together and try to harmonize the studies. And that was a great thing to do, and that really has increased the relevance of these studies greatly.
Mariam, did you have?
I think, Lily, you raise a very important question. If we have an intervention that we know brings down case fatality rate, that we know increases compliance, that improves correct use of antibiotics, clearly we need to examine that interventions also in the facility setting. So I think you lay out the next important step for how to take this forward, because I think we all here believes in that, as we've said, this continuum, family, community, facility, back to the community and the family, and to strengthen that. And I think that will also increase the comfort level that's been brought up here around, the pediatric community that often sees the sickest kids in the facilities. They come in late. So I think we really need to look at the delay factor at home, making the decision at home, how long time does that take, to the delay getting to that frontline worker, and which of course this intervention is trying to actually reduce that delay, and then the appropriate action. And as has been re-emphasized here, we're talking about the correct assessment, treatment, referral decisions, and to empower the state of art as close to the client, patient, family as possible. But I think your point is very well taken, because right now the discussion around antibiotic resistance is about facilities. It's not the front line. We're dealing with the kids who never get an antibiotic. Newborns, that's the problem of newborns. But there is that problem emerging also, of course, in facilities. And that's infection control and other quality standards, the prevention as well. So I think you raise really part of where some of the priorities for the near future.
I think over here.
Actually, Lily asked the question that I was going to ask. Asked the question that I was going to ask, but I think logically, to me, if we have good evidence that suggests the simplified protocol actually works, then you would imagine that it's more challenging to deliver quality care with a more complicated and lengthy regimen, and particularly to ensure compliance, even in a facility-based setting. But the second point was, we sometimes we use the term when hospitalization is not possible, but it's not just that it's not possible. In many cases, we're talking about clients who actually don't want to seek care from a hospital-based facility, and especially if it involves such a lengthy and complicated treatment protocol, if you will. The last question is, have we thought about or considered whether or not or how to engage private providers in this issue? In many places where we work, that is where people often go for care first, and including treatment of sepsis in the newborn. So just curious as to whether or not that's on our radar at all.
That's a great question. Any of you like to start? Maybe? Yes.
In Nigeria, the public health, the private practitioners were actually invited into the stakeholders meeting that we had in March this year. So we hope that they will get involved as this program is scaled up. Because in some communities, the first place to go to, if they decide to go, may not be the government-owned hospital, but private hospitals. So we are actually incorporating them into the various stakeholders meeting.
Any other comments there? No. Okay. Question back here.
Panel, I'm Agnès Guyon from GSI. And I have a question regarding the link with chlorhexidine, because as the chlorhexidine program is scaling up in many countries, and I'm thinking about Nigeria in particular, do we have any evidence then to bring this dual approach about prevention of infection and treatment, and maybe at the long run to have less infection if chlorhexidine move on? Thank you.
The use of chlorhexidine for cord care has actually been taken into a Nigerian policy. We did this in 2014. I was also one of the stakeholders for promoting the use of chlorhexidine. Then secondly, when we reviewed the essential newborn care package, which was also done late last year, we also included the use of chlorhexidine. Then also the integrated community management of childhood illnesses that was also reviewed in December 2014. We also included the use of chlorhexidine. So this is actually being promoted. And then recently we had another stakeholders meeting promoting the manufacturing of 4.7% chlorhexidine locally. So this is also ongoing. Then there is a program in the North currently supporting the purchase, the distribution, and then general use of chlorhexidine at all levels.
My question was more about, did we join the two programs together when we look at the study? Because chlorhexidine, I know, is rolling in Nigeria. I think we are part of the team at GSI, but I would like to know if we are considering preventing infection and putting the short-term treatment, and if we are going to move faster, because it's what we are looking is how to implement faster this great news.
The use of chlorhexidine was not incorporated into this study. The planning of this study started in 2009. Field pilot study started in 2010. Full implementation of the study started in 2011. And as at that time, chlorhexidine was not part of Nigerian policy. And it was not part of the aims of the study to consider the role of chlorhexidine. So it was not part of it.
So we conducted one of the 3 chlorhexidine trials in Bangladesh, so trials in Bangladesh, in Nepal, and Pakistan. And soon after the results came out in 2012, Bangladesh adopted chlorhexidine as a policy. The problem with the policy and implementation is a big one. I think the policy is easy one in my mind. I think you show evidence to the policymakers, they're likely to make a change in policy. The problem is, what does it mean? Is it implemented? Not really. I think so. So we have to make a lot more effort. How can we take this evidence-based intervention at a scale, or implement them in large programs, but also achieve coverage and quality? That's a question. Integration is the other thing. I think, yes, we have to integrate this intervention. We should not be just doing chlorhexidine or just a newborn infection. There are a number of interventions that can prevent newborn infection, right? I think so. The breastfeeding is on, chlorhexidine, hand washing, and we need to really, I think, make a lot more effort to increase coverage with all this intervention. But I think even if we achieve high coverage, I think the infection, I think, hopefully will reduce, but it still will remain a problem, and there will be a need for treatment of sick babies.
I think that was the last question, so I think we should stop there. And I just want to again thank all of the panelists for such a good discussion, and thank all of you for being here.